Ecmo. I would like to welcome our chairpersons, Dr. Matthew, Dr. Puneet Pundi, Dr. Kundan Mittal, and Dr. Ellen Joseph to come forward and please take the seats. Thank you.
It's my great pleasure to open this session on neonatal and pediatric Ecmo, and would like to introduce our first speaker of the day, Dr. Sunil Pavani, who is the Chief of Critical Care, Pediatric Critical Care in Dubai. Dr. Pavani is going to speak to us today on neonatal Ecmo. Not much required, or is it overlooked? Please, Sunil.
Thanks, Matt. Pleasure to hear from you again. Today, organizing committee has asked me to look at one of the very important aspects in relation to looking at neonatal ECMOs in India, but I would like to add upon SWACLSO region as well, as I represent the whole region. I would like to share my experience in different countries, how the West has been doing in relation to SWACLSO too. For improving the number of ECMOs on neonates, especially the neonates, probably we would like to have a true introspection about what are the various reasons why the numbers are not that high in comparison to adult and adult and pediatric ECMOs, and mostly in the adult ECMOs as such. I will briefly touch upon when do we need to do neonatal ECMO and the positive changes in reducing the need for ECMO that have happened in the last couple of decades. What are the hindrances to the practice of ECMO, societal wise as well as professional wise, and how can we move forward? This picture tells us about the neonatal mortality worldwide per 1,000 live births. The mortality has been high in some of the African countries, as you can see here, and probably this region represents Afghanistan. I will, in the next few slides, I will deal with the exact numbers of neonatal mortality rates. It is around 19 to 20 in India, and in the Middle Eastern countries around 16 currently. If you consider the correctable causes of neonatal mortality, which can be helped with the help of ECMO, probably they are in minority. For example, for prematurity and congenital malformations, we may not be able to offer much of help. In birth asphyxia, if treatable causes like meconium aspiration, if they come under this sector, probably we will be able to help a little bit. And then with respect to infections also, especially group B streptococcal infections seem to be quite difficult to treat. Even within India also, the figures are not the same with respect to neonatal mortality rate. They vary in different states. In some of the states like Kerala, the neonatal mortality rate is much low compared to the other states. Here as well, similar sort of pictures with the asphyxia representing 23%, and if meconium aspiration and other treatable lung causes form a part of this asphyxia and sepsis, probably will be able to contribute a little bit more in that arena, like neonatal pneumonias, etc. What are the indications for neonatal ECMO? I would like to deal with them under two headings. One is respiratory causes, and the second one is cardiac causes. Common respiratory ones are meconium aspiration syndromes, persistent pulmonary hypertension due to various etiologies, pneumonias, difficult to treat pneumonias, RDS again, hyaline membrane disease which doesn't respond to surfactant therapy, and congenital diaphragmatic hernia. Whereas the cardiac reasons, they have been persisting, and probably the indications, the numbers have been going up in this arena with more and more neonatal cardiac surgeries being done for extended cardiopulmonary bypass or low cardiac output syndrome once the babies come off bypass and then start to deteriorate. In this part of the world, we do come across late presentations of PGA and alpha. Temporarily, they might need support as well in the management of complex hearts, refractory arrhythmias, myocarditis and neonatal MI, as we dealt with a few of them uh, in the past years. So these are some of the respiratory neonatal indications. Comparatively, if in the world picture, if you look at the neonatal ECMOs and compare it with the world with the adult ECMOs, you can see the numbers have been declining here with respect to neonatal ECMOs and increasing here with respect to adult ECMOs. This may represent the fact as well in pandemics like COVID. Neonates were quite stubborn. They didn't need as much care as adults did with respect to the lung failure. So these are some of the indications where care has shifted towards adult intensive care, and more adult ECMOs are done while less number of neonatal ECMOs are being done. Similarly, neonatal ECPR cases as well, they have been growing up, and I do see increasing possibility of placing more babies on ECPR, rescuing them by ECPR as time goes on. And next, waiting for the lecture of Krishna. The other hand, we are thinking of some ways how we can increase the practice of ECPR in low socioeconomic countries. This is about center volumes for the neonatal and pediatric sectors, especially the SWAT chapter. You can see the contribution for the neonatal and pediatric ECMOs. It's a much less compared to the other parts of the world, but this may represent the fact that the referent mechanisms as well as centralized distribution of ECMO services are much better organized in Europe, UK, and in United States, North America, compared to the other places. It is not centralized in these parts of the world. So this picture is showing us neonatal cardiac cases by year. They have been varying between 7,000 to 8,500 around that, and various anomalies, the cardiac anomalies which can be dealt with the cardiac ECMO. So in the SWAT region, neonatal mortality is approximately 15 deaths per 1,000 live births in the MENA region, Middle East and North Africa. In India, it is around 19 per 1,000 live births. The target is to reach 16 by 2025. And this slide is also showing us over the years how the numbers have been increasing from 2015 onwards, where we were at 25 coming to 19 in 2021. So the technical hardships with respect to the neonatal ECMO are the smaller size of the babies, expert cannulation techniques needed, and the practice, difficulties in the coagulation in developing the hemostatic factor, so they're more liable for developing coagulation abnormalities, and the critical care transport as well. It is not very well established in the low socioeconomic countries at this point of time with respect to mobile ECMO. SWAT region is a complex region. There are government-sponsored ECMO programs like they exist in the Middle East versus private family-sponsored ECMO programs in some of the South Asian countries, including India, over here. So the concern is like if there is an indication, probably the government setup where we could go on to ECMO as per the indication, but when it is a family-sponsored program, people may not be prepared for putting their baby on ECMO with around 10 lakh rupees. If you consider that, despite the duration being 3 or 4 days duration, so finance would be a major hurdle here in improving the number of neonatal ECMOs in this part of the world. Cardiac ECMO and versus neonatal ECMO in babies with less than 3.5 kilos, as the availability of WN 13 French cannula is not that much in this part of the world. Probably people will be going for the veno-arterial ECMO using venous and separate venous and arterial cannulae. The bigger babies, 3.5 kilos and more, can have 13 French WN cannula. Cannula availability and the cost, these are the two important factors as well. with respect to the numbers. And as it is a cardiac ECMO, this post cardiopulmonary bypass, they can go on to central ECMO too at that point of time. For the respiratory indications, that is a point of concern. There is a lack of uniformity in the Middle East region versus Asian region, in South Asia region, lack of uniformity and lack of awareness as well. One of my projects for the next couple of years is to bring out this. Puneet can help me with this as well in bringing this aspect in the neonatal conferences or the perinatal conferences. So it is the awareness of people to know the importance of ECMO. Whenever I attend programs or ECMO teaching programs in the country, they say, okay, ECMO for neonates, for adults, etc. But extending it further to the pregnancy indications, how we can help the obstetricians and the neonatology, still in this part of the perinatal world, there is some work for us to do for improving the awareness. So the critical care transport programs have to be improved as well. Centralized units and law and centralized units would be welcome, but we don't have that sort of setup here in India, and the distances are long too. Still, I can see a lot of progress being made in this aspect, and the future years look rosy. For the respiratory indications, high cost of ECMO, that is one of the problems. Probably we can attend to this by resorting to insurance packages which will involve and include neonatal healthcare also, including ECMO, when the package for the delivery has been taken at that point of time as an insurance-based coverage. I cannot overemphasize the uh, importance of high cost factor of ECMO, which is prohibiting the number of neonatal ECMOs being done in the country. And it is just my assumption, as it's a newborn baby, the lack of emotional bonding with respect to spending huge amount of money that may be a relative factor compared to an adult who can be saved at even a higher cost of money as well. And the facilities of neonatal ECMO as well. Currently, they are limited to few of the centers. This has to improve as well. In our ECMO training programs, we emphasize on it. It's a common program for neonatal as well as adult program with some variations between the two practices. So that's what we would like to emphasize and improve the technical expertise. That is where we are focusing on. So it is a team-based approach, as we all know. Cannulation can be done by experienced intensivist, cardiac anesthesiologist, pediatric cardiac surgeon, or a vascular surgeon. Orientation to each other role and working together as a team is very important. And management. In my practice at Krishna Institute of Medical Sciences, Hyderabad, I developed a team, ECMO team. So when baby is there, neonatologists will get involved, or when an adult is there, adults will get involved like that. So we just continue as one single team. So rising awareness among neonatologists, obstetricians, and perinatologists is extremely important. Um, Better practices, which has probably helped a lot in Western countries, such as preventing and treating meconium aspirations, thereby reducing the role. And since 2020, nitric oxide, high frequency oscillation being available and helping in reducing the need for ECMO, those also tend to play a role in reducing aspiration syndromes. Close relationship with an ECMO center is important. So there is a need. Roadmap to tackle the problems is important, and improving the facilities for training, simulation, practice, building the relationships, access to funding, which is a huge problem in many of the South Asian countries. Delivery packages to include ECMO would be helpful as well. So probably awareness can also be improved by including this as part of the curriculum in medical students curriculum at the postgraduate level and super specialty level also. We should include this as a topic while stressing the need at our conferences, workshops, etc. So in conclusion, As we can see, obviously following Caesar trial and earlier trial, more and more adult ECMOs have been done. Pandemics have also added to this number that shows the neonatal ECMO numbers much less compared to the increasing need in adult ECMOs, and advances in the neonatal care affordability will be helpful as well. I've been supporting All India Institute of Medical Sciences of Krishna's in extending ECMO practice in public funded hospitals. So people have to spend less in these hospitals, and that would be a way to take it forward as well. Better planning, organization, awareness, and technical expertise. These are the things to be addressed for improving the number of neonatal ECMOs. Thank you very much.
Thank you for a great talk. We'll take questions at the end.
The sequence. Now we'll call upon Dr. Jayanti Kishore. She will be talking on Ecmo and congenital heart disease, indications and management.
Good afternoon, everyone. So we'll start.
So, Ecmo in congenital heart disease, we use in preoperative patients while they await for surgery when they crash actually, but not extensively used in them. Mainly used in post-cardiotomy low cardiac output scenarios as ECPR when the preoperative or post-operative patients crash. And in all these patients as for recovery or for as a bridge to ventricular assist devices like Berlin heart or hardware or cardiac transplantation if after a reasonable period of ECMO, cardiac recovery is not expected. So the criteria for commencement of ECMO. Hypotension despite maximum doses of two inotropic supports or vasopressors with reaching an inotropic score of 20 to 25. In India, I think we still wait, we extend a lot, we stretch and probably wait until the inotropic score touches around 40, 45 also sometimes. Ideally, we should not wait. The low cardiac output, as evidenced by organ malperfusion with poor pulses and oliguria, persistent oliguria. Low cardiac output with low mixed venous saturation or SCVO2 with a rising lactate and the lactate level of 4 with an upward trend, despite maximal medical management. Refractory arrhythmias with low cardiac output state and refractory pulmonary hypertensive crisis after maximal medical management. We have seen this quite a few times where patients do not respond to even the maximum medical management in acute pulmonary hypertensive crisis where we were forced to put on ECMO in one or two patients. So we'll actually start with the case and then proceed to the next literature. We had a patient 2-month-old who underwent arterial switch operation with VSD closure. He had hypotension after 4 hours. Then there was no bleeding or pericardial collection. There was only global dysfunction. Coronaries were, the surgeon was quite confident with coronaries, no regional wall motion abnormality. Inotropic score was touching 40. Then we cannulated this patient. We put on, actually the CPB circuit was at standby. We had no ECMO circuit primed, so we went on to the CPB as emergency and then cannulated the right atrium and aorta in a 3.2 kilo child. So this is the setting where the patient on the left here, you can see that it's already on CPB. On the back, there is an ECMO machine here. So there's the process of conversion going on while the OT team arrived. As per this cannula guidance chart, we used a 16 French right atrial cannula and the 10 French aortic cannula. This is the process of conversion. After this, you can see in the X-ray the tip of the atrial cannula and the aortic cannula here. So this child, this is just a process, the video of that. Nothing special about it. So this is the child after going on to ECMO the next day. He was actively moving also. We kept him a little awake. The chest was actually open. Then the flow, I think we kept around 140 mils per kg per minute. There was a little ejection while going on to ECMO, so the surgeons were reluctant to do LVent. Then lactate actually reduced to 6.2 from 11.2 within few hours. The gas exchange was satisfactory. Again, there was some flow reduction. Again after some time. So bleeding was noticed, and it was not surgical bleeding. Everything was thoroughly inspected, and ACT was raised, APTT was raised. All the coagulation factors were low. Thrombocytopenia was there, so we replaced with all the factors, and flow stabilized. So, what is adequate flow for these patients? So, SCVO2 of we target an SCVO2 of more than 70%, SVO2 of more than 70%, and we aim for a tissue perfusion which is indicated by low lactate, low atrial pressures, and low adequate mean BP for that particular agent, um, uh, targeted specific target. After some time, again next day, I think patient had raised plateau pressure on the ventilator with no ejection. He had a myocardial stun. After 11, the pulse pressure improved. On day 3, he had an AKI which required CRRT. From post pump to pre pump, we connected this, and after this, child did well. Within the next few days, had a good pulse pressure and weaned off. This is the echo showing good function. You can also see the cannula here. So coming to some literature, there's a paper from by Peter and Malaika has shown that risk factors for receiving post-cardiotomy ECMO are young age, low weight, preoperative mechanical ventilation, arrhythmias, high vasoactive inotropic score, high stat score, and CPB duration and shock. Surgeries like Roscono truncus and arterial switch, Alcapa and TAPVC required ECMO mostly. And the data, as per the STS database, 70% mortality was recorded for documented for truncus and Roscono, and 15% for El Kappa. In our hospital, we actually used to use extended CPBs in the beginning because our hospital was reluctant to start ECMO, and with extended CPBs, we sent almost 40% of the patients home. A few of them had neurological injury, but most of them had no issues. And then they were a little confident, and they supported us. Now we started doing ECMOs for these patients. I think on extended CPP, the longest was for 72 hours. The only disadvantage was we had to use the longer, higher ACTs and all that, and a lot of blood products were used in those patients. There's the same paper showing an overview of multiple studies, and here we can see that Chaturvedi et al. And Kolbis et al. Have shown that early ECMO, if early ECMO was used in the OR, survival was better with a good statistical significance. Again, the same thing with the Kepler-Mayer showing better survival with a theatre start than the CICU start by Chaturvedi et al. Here we can see that the ECMO was used in both acyanotic and cyanotic heart diseases, and most of the runs were used in hypoplastic left heart. This is literature from the West, but here we don't use much for the HLHS. The survival in all these disease lesions was between 40 and 50% only. So again, like Chaturvedi et al. Had shown that survival was much better in the TAPVC and left AV valve replacements, followed by arterial switch. In their group, tetralogies did not do well because of the myocardial necrosis. And Corsandi et al. Have shown that the results were poor in, not poor, in fact, lower than the bigger children in less than 6 months old, maybe because of the complex anatomy and other risk factors. And again, they showed that the end of theatre ECMO was better than the CICU ECMO, although statistically it was not significant. Again, in the first few days, our results were better. If the ECMO had duration crossed 10 days, there was 0% survival here. And Shah et al. From UK had shown that there was only 37% survival to hospital discharge, and they identified high lactate and prolonged ECMO duration to be the risk factors for mortality. And another study from UK, 53 patients, showed that the prolonged ECMO duration, RRT, neurological impairment, bleeding were the determinants of mortality. This is a paper from adults, where again they also showed that early ECMO was better, and duration of ECMO and length of the stay was also less in in patients who received early ECMO. The lactate clearance was again better in the early ECMO group. ECMO duration, renal failure, and single ventricular physiology are the determinants of in-hospital mortality. And residual lesions, this is very important because most of the congenital heart disease patients who undergo surgeries are stuck with residual lesions on ECMO. So we need to address them and identify them fast and address them. Otherwise, we'll be prolonging the ECMO, which again leads to a lot of other complications. So multiple studies have shown this, and Cato et al. Had shown that CAT done within 48 hours after ECMO cannulation had better survival. And Hings et al. Have shown that ECMO duration of less than 2 days had good outcome in neonates. And in fact, cardiac cath was better than transthoracic echo for identifying residual lesions. And a lot of residual lesions like this were identified in less than 3 days of ECMO support. So, what about ECMO in BT shunt? BT shunt is a shunt from the subclavian to the pulmonary artery. It's done in a single ventricular low pulmonary blood flow situation or HLHS situations scenarios. And in this, it's a little tricky because most of the BT shunts, if they have a problem, they either have pulmonary overcirculation or the shunt under circulation or the thrombosis, and they actually may require revising of the shunt. But meanwhile, we also require ECMO in certain scenarios. Here, the strategy is either to partially clip the BT shunt or leave the BT shunt and run high superflows of ECMO. So people have done both, and I think many people prefer that leaving the BT shunt open and running higher flows is ideal than clipping the shunt, as it can cause thrombosis. And in these patients that we've shown, the literature also shows that the lactate clearance is actually delayed as compared to the non-shunt group. ECMO in single ventricle Glenn and Fontaine patients. So Glenn is an anastomosis between SVC and pulmonary artery, and it's a passive circulation. There is no subpulmonary ventricle, so it's mostly dependent on the gravity. So basically, these children can have high transpulmonary gradient or the raised common atrial pressure, or the normal transpulmonary gradient with raised Glenn pressure, and there are quite a few scenarios like this, and it can happen in Fontaine also, where in Fontaine we connect both SVC and IVC both to the pulmonary artery. Both are passive circulations. So here there are different strategies for cannulation. We do IVC to aorta, and in Fontaine, from the Fontaine baffle to the aorta. Sometimes we may have to cannulate the SVC also. This is a chart, is a table showing the cannulation methods via peripheral method or the central method. And if central method is used, the common atrium is used. In Fontaine's, the baffle is used. Otherwise, rest are all quite almost standard, internal jugular and femoral, internal jugular vein and carotid artery or femoral artery in bigger children. Additional venous cannula may be required in children. So, what is the strategy for Glens? So, we need to look at, consider the anatomical variations like bilateral SVCs also, and isolated venous cannulation and drainage of IVC will be adequate in some children, but some of them who have poor ventricular function with raised LVEDP, raised restricted atrial septums, pulmonary stenosis, elevated PVR, additional cannula should be inserted in the SVC for better drainage of the upper end of the body. If timely cannulation is not done, then we might end up in neurological injuries, because these patients we need to do preemptive ECMO. Otherwise, if we actually wait till the ECPR is done, chances of neurological injury is high, as with every compression in the CPR, the systemic venous pressure rises, and there is a risk of organ injury and ischemia to the brain and other organs. So it's always recommended to cannulate the SVC before the IVC to minimize complications. In Fontaine, ideally, theoretically, single cannula should be enough from the Fontaine baffle, but usually for better practical purpose and better drainage, two cannulae should be inserted into both SVC and IVC for decompression. And to avoid stasis, some people also do VAV hybrid ECMO, where the return goes back into the IVC and then go to the aorta. If we do hybrid ECMO, we have to regulate the return blood by putting clamps wherever it is we need to control it a little more than what we require. So this is a paper by Carol et al. Which shows that out of 14 patients of Fontaine, half of them required additional cannulae. And of the 6 patients in Glen Physiology, 3 of them, so 50% of them required additional cannulae, and a few of them had neurological injury. They also showed that almost many of these patients had raised TPGs or Glen combinatorial pressures and PA pressures, and half of the Fontaines recovered in these group, and almost all of them went except for one patient. All of them could be discharged. In the Glen group, 50% again survived to decannulation, but only one could be discharged. So the Glen group is even more riskier group than the Fontaine actually. So, in summary, early Ecmo is preferred to avoid ischemia and organ injury. Inability to wean off CPB can indicate serious pathology. Actually, a few studies have shown that if the patients require early Ecmo in the theater, or so there can be serious pathology, and that's something like residual lesions which need to be identified early. And individual strategy for cannulation and ECMO flow should be adapted for various anatomical variations. We need to consider bilateral SVCs, interrupted IVC, and sending anatomy, etc. And ECPI should be done only if we can maintain effective perfusion to the organs. Otherwise, we should not do that. Thank you.
Think you're ready, Dr. Said?
Yes.
Okay. So I'd like to introduce Dr. Saeed Ali Masad Al-Shami. Anshi, sorry. Apologies for butchering. He is the senior consultant of head of pediatric intensive care at the Royal Hospital of Oman, and is here to speak with us today on ECMO decannulation in children with post-cardiotomy shock. When to do this, and that's the aftercare that we do. Thank you, Dr.
So I'd like to thank initially the organizing committee for giving me this opportunity today, and many thanks for their excellent organization for this summit. Actually, I'm going to talk basically about post-cardiotomy syndrome, and because of the constraint of the time, I'm going to talk about 3 aspects. Optimal timing for ECMO, PC ECMO, factor that influence survival and duration of PC ECMO. Hopefully that this will enlighten us on deciding for how long we can keep patient with patient on BC, whatever BC ECMO. BC ECMO is used actually to support medical patients with a refractory shock after congenital heart surgery who are unresponsive to conventional treatment. It provides a break to myocardial recovery by decreasing cardiac workload and enabling recovery of cardiac function after injury. It's estimated that around 0.5 to 6% of children who require BC ECMO after congenital heart surgery. And there are many indications, but the most common indications are by far patients with low cardiac output syndrome, those who fail from being weaned from off cardiopulmonary bypass, and those who are cardiac arrest and unresponsive to conventional CDR. Also, annual report showed that neonates and children who are less than 1 year are the largest group of patients who are using PC ECMO, and neonates by far the most common indications for PC ECMO are those who have normal procedure, those who have complicated ASO, and those who have MSK. And those who are beyond the neonatal period, the most common indication for their requirement of ECMO is in those lesions with left right shunt physiology. Regarding optimal time, actually, it's not definitely determined. And many studies they showed that there is association between delayed ECMO initiation and poor outcome. But the best time to initiate ECMO is prior to development of severe hypoxia, hypoxia and organ dysfunction. And as metabolic acidosis is a marker for poor oxygen delivery and tissue perfusion, it is shown that the severity of pre-ECMO acidosis is found to be an independently a factor associated with increased mortality. In fact, those patients who survived ECBR in this study had higher median PO2 and also higher arterial pH before ECMO. The same study showed that 50% of those who died within 72 hours were having the pH of less than 6.9, and majority of those actually met brain death criteria, which indicate that severe metabolic acidosis prior to ECDR is a marker of poor outcome, where the utility of ECDR should be carefully considered in the found metabolic acidosis, but these patients are at high risk of neuro injury, and they are very unlikely to survive, as it is shown in here that those patients with profound pre-ECMO acidosis, they don't survive. The third study which tried to find out optimal cutoff value as an outcome predictor, like in this study, would show that pre-ECMO pH of more than 7.2 is associated with better survival than those who are less than that. And they found that overall accuracy of prediction is around 80%. Another factor for optimal timing is considering area deployment of patients with ECMO, particularly those who are unstable. And there's a lot of debates whether cannulation in OT is better than ICU, but this study showed that the survival was significantly higher when ECMO was initiated in OT as compared in PSU. It just indicates that early, effective support prevents prolonged hypoperfusion and also avoid catastrophic cardiac arrest, which is also shown in this study that initiation outside OT is associated with poor outcome. However, there are also other studies which show that there is no difference between the two. Another factor for optimal timing is considering is the time from conventional ECDR to the deployment of ECMO. And the study showed that the longer time for ECDR is associated with poor outcome. And actually, it showed that for every 5 minutes increase in time from conventional CDR to deployment of ECMO, the odds of death increased by 4%. Which is also shown in also history that pediatric ECDR had lower survival to discharge as compared with other cardiac indications. Just to say that patients with congenital heart disease, they have physiological constraints that limit their effective conventional CPR, particularly chest compression. It affects those patients with limited stroke volume and those patients with limited effective pulmonary blood flow, and also cause reversal flow in patients with heavy insufficiency. That's why in those patients with after surgery who require ECMO, the ECMO team should be activated as early as possible during an acute event. So we can conclude here that no consensus on optimal timing, because studies show conflicting results, but early initiation of ECMO facilitate unloading of vulnerable myocardium, and of course prevent acidosis and cardiovascular collapse. So generally we should start ECMO prior to deployment or by the development of severe tissue hypoxia and in organ dysfunction. Survival to hospital discharge after ECMO is found to be around 40 to 60%, and there are many factors actually influence the survival. One of those is weight. In a study of infants who are weighing less than 3 kilos, it was found that only 20% of patients who are weighing less than 2.5 survive. And in another study, which they well-validated single ventricle, showed that only 10% of those patients who survive, 10% of those patients who have blood syndrome diagnosis and require ECMO, only 10% of those who are weighing 2.5 kilograms survive, which is also indicated this large PHO history, which shows that those patients with weighing 2 to 3 kilograms, they have lower survival than other groups. Actually, it also indicates that those patients who are less than 1.5, they don't survive Ecmo. We might say that the weight of less than 2.5 kilogram is a critical weight cutoff for outcome. Another very important factor for survival to hospital discharge is the complexity of congenital heart disease. And in this study showed that those patients with normal and those patients with truncus arteriosus and Roscoe, they have higher mortality than others. Actually, another indication, other factor for survival to those survival to discharge is the indication for Ecmo. It was found that the indication for Ecmo is stronger predictor for survival, and those patients actually who require Ecmo for cardiovascular collapse, they have lower survival than those patients who require Ecmo for emphysema. Another very important factor is the development of acute kidney injury and the need for renal replacement therapy, which is in many studies actually showed that it's commonly associated with poor outcome. And this study showed that only 23% of those who require CVHD and Ecmo survive as compared to those who didn't require CVHD. It is shown that AKI is, in many studies, show that AKI is a significant factor for hospital death, and those patients who require renal replacement therapy was found to be the only predictor factor for good survival in this study, which is required actually for AKI and fluid overload. Again, this study showed that mortality is higher in CRP and patient with Ecmo. The good thing is that the recovery is good in those patients who survive. Just to say that that the poor prognosis, which is poor prognosis for those patients who require CRT or Ecmo, is not related to the treatment itself, but because of the increased risk of death due to acute kidney injury. And RRT requirement actually can be used as a marker for patients at higher risk of death. Institution, we can say, on the other hand, that institution of Ecmo is associated with period of oliguria and anuria by itself. And a combination of fluid and fluid overload worsens heart and lung disease, and can, as it's indicated in this study of patients with Ecmo and ARDS, which show that mean body weight for non-survivors increase over dry weight by 10% as compared to those who survive, where there's decrease in their body weight of less than 5%, with clear association between ability to retain patient to dry weight and survival rate. Another very important factor is the development of complications, and here it shows that the odds of death ratio increase by increased number of complications. Lastly, there are many studies also show that there is poor, the longer the duration of each Ecmo support the higher the mortality. And like in this study, multi-center study with good number of patients, show that around 30% patients require Ecmo for 1 day, around 40% for 2 days, and 25% for 7 days. And the median duration of Ecmo in all centers is for around 4 days. It shows that the probability of patient death increased by increasing the duration of Ecmo days, and that there's 18% increase in mortality for every 24-hour increase in Ecmo duration for more than 47 days. And then the mortality of more than 7 days for those patients who require Ecmo for more than 7 days. This study showed that the survivors have shorter duration as compared with those who are non-survivors, and actually those patients who are Ecmo for more than 231 days will have more survival. And in this study showed there are only 2 patients survived out of 16 patients who require Ecmo for more than 230 days. Again, in Ecmo registry of millions, it showed that the greater number of hours on Ecmo is independent risk factor for non-survival. What are the reasons for requiring prolonged Ecmo support and high mortality? In the previous study that I mentioned with the millions, showed that survival was significantly improved on those patients who are Ecmo less than 200 hours compared to those who are more than 300 hours, which indicate that the need for prolonged Ecmo is indicate irreversible myocardial dysfunction. The same study shows also that among patients of Ecmo support of more than 200 hours, around only 5% of those patients who were supported with Ecmo, who have HLH and support Ecmo, survive as compared to clinical survival of those who are HLH, which is another reason that would show that the difference in diagnosis play a significant role in outcome, which also plays a significant role in discontinuation decision of Ecmo. Another factor is the development of multi-organ failure. And as a surrogate, multi-organ failure can take acute injury. In this study, it showed that the increased duration of Ecmo is associated with development of peritoneal failure. We can see that the longer the Ecmo duration, the lower is the GFR. It is found also that odds for developing acute renal failure increased by 60% per day of Ecmo support. One last very important factor which was mentioned by in the previous lecture is presence of residual lesion. And in this study where residual lesion have been evaluated for 43 patients, 190, in those patients who are unable to be weaned from Ecmo, it was found that hemodynamically significant residual lesions require intervention was found in 28% of patients, and that majority of those patients require cardiac catheterization. And it showed that the earlier detection and intervention of residual lesions of this time 3 days in group 1 as compared to more than 3 days in group B, show that there is significant improvement in successful degeneration and also GDAR survival to hospital discharge. Just to conclude that patients may sustain significant cardiovascular failure despite prolonged Ecmo support due to sustained irreversible myocardial injury, progression of underlying disease, failure of aortic cardiac surgery, and those with underlying cardiac lesions. And actually, those patients who may benefit the most from PC Ecmo support would be those patients who have potentially reversible cause leading to Ecmo, those without residual cardiac defects, or those who have cardiac defects but they have earlier detection of their residual lesions and intervention, and those who have uncomplicated Ecmo course. Thank you very much.
It's my profound privilege, in fact, to introduce our next speaker, Dr. Aparna. She is such a dear friend. We met first time in the year 2001 when she was doing fellowship in cardiac ICU and I was visiting fellow at PICU at Gosh, London. And it's a matter of pride that now she is heading that cardiac ICU of Gosh. Gosh is a Great Ormond Street Children's Hospital, one of the top hospitals of UK, which is a main representative for Ecmo and heart transplant. She is also a chairperson of ESPNIC, which is again the European Society of Paediatric and Neonatal Intensive Care. She's got many international publications, and we are so happy to have you here, Aparna. Over to you. She'll be speaking on cardiac cath on pediatric cath. Thank you.
Thank you, everyone, and thanks to the organizers for an invitation to come to lovely Ludhiana. And Puneet, it's been such a pleasure to meet you as well and get to know you once again. So it's really nice. So I'm going to talk about cardiac catheterization on Ecmo in children. And I will go quickly as you've already done a very nice introduction. So I'm going to focus on the role of cardiac catheterization. I'll talk a little bit about the indications for cardiac catheterization on Ecmo. I'll talk about diagnostic and some therapeutic indications, how to interpret data of cardiac catheterization on Ecmo, some complications, and specific case scenarios. So we know that the use of cardiac catheterization is particularly in children who have been supported for Ecmo for cardiac reasons, and the indications focus on either a cardiac lesion that has resulted in either hypoxemia, or where you're looking for a bridge on Ecmo to an intervention. The other situation where you use cardiac Ecmo is the post-cardiotomy Ecmo, and Said has done a very nice talk already on post-cardiotomy Ecmo. And the indications for post-cardiotomy cardiotomy ECMO are usually low cardiac output state, unexpected cardiac arrest, failure to wean from bypass, disproportional cyanosis, or refractory arrhythmias. The other situation where you might need to use catheterization is acquired heart disease, cardiomyopathy or myocarditis, where you're using catheter to offload the left ventricle. So cardiac ECMO, I focus on two important principles. And the first important principle is to have appropriate decompression of the heart. And why do we need to do that? It decreases cardiac work, myocardial performance is better, oxygen consumption, wall stress is reduced, and it aids recovery. So it's important that we maintain low central venous pressures, we monitor the left atrial compression clinically as well as by echocardiogram. If you're having a distension of the left atrium or the left ventricle or mitral regurgitation, or if you see pulmonary edema, then that's a late sign. So treatment usually involves a balloon-atrial septostomy or a surgical vent in a post-cardiotomy. The second very important principle is to identify and diagnose any potential correctable residual lesions. And this is really, really important because if you do not correct this, then the chances of success coming off ECMO are low. And we've already heard about this paper, which has been quoted before, published in 2004, where they looked at the first 100 patients supported for cardiac ECMO after biventricular heart surgery. And you can see that the important adverse factors for hospital survival were serious mechanical ECMO circuit issues, the need for renal support, any residual lesions, and long duration of ECMO. So residual lesions, we know that there are many papers which now support the fact that if there are residual lesions, they need to be corrected. And this is a very old paper from Sick Kids Toronto, where they found that 70% recovery was seen in those without residual lesions. And this is another paper looking at the support of ECMO support in neonates supported after cardiac surgery, and 83% of them had residual lesions. And this is another paper which again says that 28% of the patients in post-operative pediatric cardiac surgery, which was a mixed bunch looking at neonates and pediatrics, 28% had lesions. And this has already been shown that early intervention, so early identification and early intervention is very, very important. And the outcome is better in those who don't have any lesions at all. So how do you diagnose and manage any residual lesions? We know that echocardiogram, which is frequently used, has got multiple caveats. Now, transthoracic echo, it's difficult in the presence of open sternum, dressings, and cannular positions, which can obscure echocardiographic images. Transesophageal echo is tricky when anticoagulated patients, and the flow through an aortic cannula itself may produce or exacerbate aortic insufficiency. So what are the indications? The indications are assessment of the operative result, a percutaneous left heart decompression in those who needed myocarditis or a cardiomyopathy assessment, hemodynamic assessment even for the non-postoperative patients, any planned catheter-based interventions, or if there is any arrhythmia mapping and ablation. And there are other reasons here which have outlined too. So the most important thing when you're considering cardiac catheter is the timing and the clinical context. So in a preoperative or when you're diagnosing a situation, a patient has been supported on ECMO, for example, with severe hypoxemia, or there is severe collapse, and then you're trying to identify if there is a correctable lesion. And you can see here either it might be a neonate with critical aortic stenosis, not obstructed arch, or if there is a severe right heart obstruction, then you can do a procedure to help open up this obstruction till you can do corrective surgery. So it buys you time. Now there are also papers coming up which look at elective ECMO for complex cardiac catheter procedures. And you can see in this paper from Boston Children's Hospital that children who had elective cannulation for high-risk EP or interventional procedures had far better survival in comparison to those who had eCPR in the catheter lab. And so this is a new indication and which is being increasingly used in cath lab. How do you decide who needs catheter? So it's usually on an individual case basis, and it has to be a multidisciplinary team approach. As soon as you have a situation where a patient is supported on ECMO, you need to get together the key people involved in the decision-making process, and this has to be a multidisciplinary team. You have to use your clinical judgment when the potential for new information gained at catheterization outweighs the risks of catheterization, and it's believed to be crucial to optimize patient outcome. An early catheter is very important. Wasting time waiting doesn't really benefit the patient. And there are many studies here which show that children who have had early catheterization and early intervention after cardiac surgery were more likely to survive. Now, there is something important which I'd like you to all understand, that hemodynamic assessments on cardiac catheter may be unreliable in the face of limited intracardiac flows or ventricular filling. So, therefore, interpretation on Ecmo of cath findings has to be very carefully done. So, flow to the aortic cannula may produce or exacerbate aortic insufficiency. So, how do you circumvent this? Certain diagnostic procedures or maneuvers require temporary reduction or cessation of ECMO flow. So the ECMO physician is a very key part of the catheter procedure. You have to remember that sometimes the heart has to be volume loaded. On ECMO, on full ECMO flows, the heart is totally volume unloaded. And if you want to assess pulmonary arteries and the branches or the outer tract obstruction or coronary blood flow, you need to have good LV loading. But you can use catheter for diagnostic and interventional procedures, not only to give you an assessment of the operative result, but also for hemodynamic assessment. And you can do either a percutaneous left heart decompression or a stent placement, and as I previously mentioned, arrhythmia mapping. Now, this is an example of a child with double-ended left ventricle with transposition of great arteries where arch reconstruction was a late presenter. And you can see that this child had severe pulmonary hypertension, had to be placed on ECMO in OR. We took the child to cath lab, and you can see that the pulmonary artery pressures are high, significantly high here. And then this child had the catheter to look at how the arch was, and you can see both these images show that the arch was good even in the pullback gradient. But what they found in the pullback gradient was that there was a significant gradient between the ascending aorta and the descending aorta, which you can see in the box here. And this implied that there was significant afterload produced by the cannula. So the child was converted to neck cannulation, was given more time on ECMO, more pulmonary hypertension treatment, and then there was successful decannulation. Cardiac decompression is something which I think is very, very key for recovery of heart function. And we know that in VA ECMO patient, if you have the aortic valve that is not opening very well, then that causes back pressure. And when there is back pressure, you have severe mitral regurgitation. And in these situations, cath lab, you can do balloon atrial septostomy. And how can you do it is, I'll show you here in a minute in this cardiac cath video here. You can see that there is very carefully placed catheter in the left atrium, and then there is a pullback, and you can see the dramatic improvement in the chest X-ray. The top X-ray shows pre-pullback, and you can see the one later on when there is effective decompression of the heart. So when I speak to my cardiac cath colleagues, and they always tell me that the biggest balloon that the operator feels comfortable with is the one to be used, and you can see that here in the left-hand panel. You can see that there is a communication created. And again, very important, again, you can see the marked difference in the chest X-ray after, decompression, which was done by septostomy. Now, we have to remember that in certain children, when you have restrictive cardiomyopathy, the septum is very difficult to navigate. And in these patients, it may not be able to puncture. And in these situations, you sometimes may have to put an atrial stent. Other catheter procedures that you can do on ECMO include biopsy, which could be the left ventricle, the right ventricle. You can do pulmonary valvotomies. You can assess the pulmonary arteries and stent wherever necessary. If you have post-transplant a situation where there is a complex issue, you can stent rather than go back and repair. And if there are any reasons why there is either like a pulmonary artery branch issues, post-arterial switch, you can address that with a stent. Also remember that our catheter colleagues can do PDA occlusion and ablation procedures. This is an example of a transseptal left ventricular biopsy, and these again can be quite tricky to manage. And this is a situation, one of our patients who had a very complex ablation procedure done, and you can see these are very pretty pictures which show the operator how to navigate and how to move these when there is a situation where you have to identify, and here the red bit that they've identified is very important as the one that they're going to ablate. And you can see more of this. These are little slow-moving video images, but this is what our EP doctors are using these days, and this can be done on Ecmo very easily. So there are other things that you can do as well on cardiac catheterization on Ecmo, and this is quite a salutary situation. We had a child who had severe aortic regurgitation. You know that these children you cannot support on Ecmo, you cannot do ventricular assist devices, and our catheter colleagues put a melody valve in the aortic position on Ecmo, and this child then went on to be supported with a Berlin heart. You can see survived to be as a bridge to transplantation. We've already heard about stage 1 Norwood in the post-cardiotomy Ecmo, and as a need for, as one of the most important surgical procedures that gets supported on Ecmo, even in the ECLS registry data set. And here you can see that sometimes you need echo, you need cardiac cath, you need ICU data, and a catheter intervention that supported the arch obstruction and reduced that. And this is another situation where we had Norwood ECPR, and again a very difficult situation where there's a problem with the arch, and this child was also had intervention, had surgery, and then was subsequently did well to come off ECMO. Now, cardiac catheterization poses challenges, and it's important to remember that it needs a very well-balanced team of highly skilled teams who are take these children to cath lab, who are experienced in managing these procedures in cath lab, and the logistics of transfer can be complex, labor intensive. You need experienced personnel, careful communication. You need a role allocation, emergency numbers, timeout, and a backup plan. We also need to remember that there are technical limitations of catheter-based interventions on fully heparinized patients, and we've had situations where there's bleeding, hematomas, post coming back from cath lab. There are also some complications that we need to be mindful of. And what can these complications be? They can be perforation of the left atrial appendage, the left free wall can be easily perforated through. Entrain air, the echo pumps are rather powerful, and you can have access-related complications like bleeding and ischemia. So this is a situation in a patient where you can see that there was a transseptal puncture done, and what you see here is something that you'd not want anyone to see. Here, the needle and sheath has gone through into the ascending aorta where it was not meant to go through, so therefore this child then had to have a surgical exploration to allow a safe withdrawal back into the right atrium. And it was a fistula which was seen within the right atrium and the aorta, which was seen and repaired, and then a surgical went to be placed. And this is an aortogram here. Again, you can see that it's good to have transesophageal echocardiography to guide the position of the aorta. The perfusionist can give a good handshot of the contrast in the aortic circuit, and the pacification of the aortic root is usually very good. And this is a situation here when you see a nice pericardiogram, and in this again, it's gone through the heart, and what you have to do here is sit tight, do nothing, get the surgeons to come, and and hope that then this can be withdrawn under careful monitoring. So modern pumps can be very powerful, and they can, you can see air. You can see here that the whole left ventricle is filled with air, and you can see here that this air in left ventricle was aspirated under fluoroscopy guidance. So, so this is something which we need to bear in mind. So to end, cardiac catheter on Ecmo is an important diagnostic tool for patients with failing circulation. It needs to be considered early in the course. Do not wait. This is a paper which has been quoted before in the previous talk, again, which shows that early intervention is important. And again, in this paper, what they found was that early intervention, good assessment on catheter gives better survival. Any cardiac catheter procedure in Ecmo needs the backup of the cardiac surgical team who need to be on standby for any complications. And cardiac catheter on Ecmo can be safely performed in experienced hands. Hemodynamic assessments yield diagnostic information that enables therapeutic interventions. It can facilitate the diagnosis of residual lesions that would limit the successful bleeding from Ecmo, and early catheter and subsequent interventions may facilitate recovery of the myocardium. So early MDT, institute that early, ensure good planning, prepare for any complications, maximize the opportunities to do full assessment, remember the caveats for interpretation on ECMO, and plan early intervention and monitor complications. So with this, I thank you for listening to me, and if you have any questions, I can take that later.
Excellent talks by all the speakers. The house is open for discussion or any questions.
Please. Question? I'll just have one, and it's more of a comment that we saw several times during these talks, especially during Sunil's talk, about the importance of awareness of all of these problems. You know, if you're not aware of how common residual lesions are, you're not going to go look for them. If you're not aware of the need for ECMO in neonates, you're not going to ask for it. And one thing I would just push is reach out to your colleagues that are even outside of the ones who do ECMO. Sunil made a good point of going out to the obstetricians, to the perinatalologists. Those are very important people to talk with in reducing potential morbidity for neonates. At my center, we used to do adults as well. And so I've had 3 times now a case where we've had a mother who's pregnant, this goes to Huda's talk this morning, get bad ARDS for some reason. The obstetricians immediately said, let's take the baby. The baby is 24, 25, 26 weeks of gestation. In all 3 of those cases, mother survived beautifully. Baby ended up with massive head bleeds and, you know, and the problems thereof. And so, again, that's where a case of education and awareness to these folks to say, no, leave baby inside. Bring mom to us. We'll take care of her with ECMO, and then we'll have a good outcome for both. So again, I appreciate all of the speakers highlighting in their talks about the need for awareness of these relatively rare problems. We'll move to the next set of moderators and next talks. Thank you very much.
Thanks.